Okay, assalamu alaikum wa rahmatullahi wa barakatuh. Back to real life.
Beautiful. Thank you. Thank you.
Okay, for many years, for last 20 years, it's like Oprah says, if somebody got a lesion artery, a stent, and if again, a stent, and if a third time, publish it. So we need to move away from that mindset to when to not stent. Okay, so we're going to show you the evidence. People talk about evidence. We need evidence. Okay, let's see the evidence. I hope the mindset will change by the evidence. So I'll ask Ali Masoud, Dr. Hani Raghi, and two speakers here, Dr. Hussien Heshmat. Where is he? Please come here. So we have a strong team. Right. So we're going to start with Dr. Jonathan Anton. So the question is here. We have a new data. You've seen it. How many of you been to TCT 2025? Yeah? Who was laughing and who was cheering? Who was sad that day? I was happy. I hope all of you happy for that. Results of DeNovo. Finally, we have DeNovo big results, randomized trial, DCB provisional stenting versus stenting, protein stenting, non-inferior. Despite only 28% use the devices. I hope if they use it for 100, would have been a better. But anyway, we're going to discuss that one, discuss the design, discuss the when to choose patient for DCB, and when do you think the lesion is enough, that will see by Hussien Heshmat, of course. Then we'll have discussion open by Dr. Ali Masoud and Hani Raghi to tell us what's happened in real life, then open for you as well. So we're going to start with Professor Hinton, please.
Thanks very much, and thanks to the organisers for giving me the opportunity to share my thoughts on the results of the SELUTION DeNovo study. I have the usual conflicts that you'd expect, and Cordis have reviewed these slides, but these are my own thoughts. I also wanted to start off by saying it's great to be back in Dubai. We were here earlier this year, and I was absolutely blown away by your incredible hospitality, so thank you very much. Why does all this matter? Well, we know from data that there is a gradual accrual of events with stents, and this carries on maybe 1 to 2% per year. And of course, if we've got young patients, they've got a long time to live with this, even with modern drug-eluting stents. We also know that until recently, the only data that we've had regarding de novo large vessel disease with DES versus DCB were the Rett cage-free study. And as you'll all be aware, that did not meet the non-inferiority margin, particularly in those large vessels. Finally, we also know that drug-coated balloons behave differently. This is one study comparing the Magic Touch versus the Sequent Please balloon, and as you can see, there was a difference in terms of the late lumen enlargement. So we know that there's a gradual accrual of events with stents. The only prior DCB versus DES study in large vessels failed to show that DCB were non-inferior, and drug-coated balloons all behave differently. But we know from history that limus has worked well in stents. But the problem here is that it's actually quite difficult to deliver limus in good concentrations and keep it in the vessel wall long enough to allow vessel healing. So what's different about SELUTION? Well, it's a combination of factors, but particularly these sirolimus spheres mixed with a biodegradable polymer. And what that does is it absorbs into the tissue and allows prolonged release of the drug, which allows it to cover the healing cascade. So SELUTION provides sustained drug release. This is a busy slide, I accept, but you can see each of the blue curves represent one stage of the inflammatory process after vessel wall injury. The little dotted line at the bottom shows the minimum concentration of drug required to have an effect. And you can see that either in de novo or restenosis lesions, SELUTION maintains that sirolimus out to the 90-day window, allowing vessel healing. We also know that sustained limus release is not ubiquitous. This was an animal study where they compared SELUTION versus Magic Touch versus the Xience stent. And you can see what they did was they looked at the amount of sirolimus left in the tissues, and looked at the outcome, how much was left after 90 days. And you can see in orange, solution performs very similarly to a Xience drug-eluting stent, whereas Magic Touch does not, highlighting that drug-coated balloons, drug-eluting balloons, are not all the same. Let's move on to the results of Solution DeNovo. It's my honor to be able to present it here following TCT this year. This was a randomized study of 3,326 patients who were randomized prior to any lesion preparation. So we saw the vessel, we thought it was appropriate, and they were randomized either to the drug-eluting stent, which was the market-leading option in our hospitals, or to the solution balloon. And we used the DCB consensus guidelines to tell us whether we had done a sufficient treatment to allow drug-coated balloon implantation. So if we had an acceptable angiographic result, which essentially floated around no flow-limiting dissections, and I'm sure we'll talk more about that later, residual stenosis less than 30%, and TIMI-3 flow, then we went on and put a drug-coated balloon, the solution balloon, in. If we got a suboptimal angiographic result, we then went on and put in the stent of our choosing. Looking at the key inclusion and exclusion criteria, this was a relatively broad inclusion criteria, including vessels from 2 to 5.0, and there's no limit on the number of vessels you could include, and you could include them relatively soon after ACS or STEMI. And this also included stable ACS presentation, so unstable angina and end-STEMI. The exclusion criteria were STEMI, unstable end-STEMI, left main disease, graft disease, CTO, and obviously in-stent restenosis, because it's a very different population. So I'd say that the inclusion criteria here are actually quite broad, surprisingly broad, and this meant that a lot of the people coming through my lab went into this study because the exclusion criteria were quite narrow. This was a truly multinational effort, and of course it's not a competition in life, but with Dr. O'Kane, our PI, we were the third leading recruiter internationally. Let's look a little bit at the baseline characteristics. We can see here that they're pretty well matched, but I will highlight that a third of these were acute coronary syndrome patients, and that forms a lot of my practice. And so I thought I would share one of the cases that we did in Solution DeNovo. It's a young man, end-STEMI, stable end-STEMI, and he's got this right coronary artery, obviously 2 severe lesions, and he gets randomized to drug-coated balloon. I'll come back to that in a minute. Let's look at the angiographic characteristics. Well, we know that nearly 20% of these patients had proximal LAD disease, and this was a study of large vessels, so 2/3 were greater than 3.0. There was a significant proportion of bifurcation lesions, significant calcification in around 20 to 25%, and these were not all simple lesions like in rec cage free. Let's look a bit more at the procedural characteristics, because I think this is worth some time on. Unsurprisingly, given the vessel diameters, the nominal device diameter was 3.1. And this is interesting. So we talked about when we'd cross over to using a drug-eluting stent. And in around 20% of patients, we had to cross over from the solution arm to a drug-eluting stent arm. Interestingly, the procedure time was quite similar, and specialty balloon use was much higher in the solution arm, probably because we knew we were going to be using a drug-coated balloon, and therefore we wanted to prepare the vessel further. The truth is that these numbers, both in the DES and the drug-coated balloon arm, are relatively low, but they reflect real-world practice. In this case, we used an angiosculpt, a 3.5 angiosculpt, as part of the pre-dilatation strategy. And again, intracoronary imaging, slightly higher in the stent arm. I don't know the statistics behind that because they've not been published yet, but the rate of imaging in the stent arm was actually relatively low when we consider that this is now class 1A in complex lesions. But of course, again, this does reflect what is happening in real world. We used intracoronary imaging to help guide us in this procedure, and then we went on and put a 3.5 and a 4.0 solution drug-eluting balloon. And this was the final result, and I'm sure we'll talk more about this. So you've got dissection proximally and more in the mid-vessel, but TIMI-3 flow, and we met the criteria. So we finished there. Now let's look at the primary endpoint, which was target vessel failure at 1 year. You'll all have seen this before. In the drug-eluting stent group, 4.4%. In the solution group, 5.3%. And this met their variable non-inferiority margin, which I'm sure we can discuss later. People often say to me, well, 20% of the solution patients had a drug-eluting stent. Surely that's what's keeping the event rates low. But as we saw when it was presented, if you exclude those who had a stent in the drug-eluting balloon arm, the event rate was actually 5%, which suggests that it's not the stents holding the balloon up. You can see the Kaplan-Meier curves follow quite closely together. What about the individual components of that composite endpoint? Well, cardiac death, slightly lower in the solution arm, but of course, I don't know the statistics, but that looks unlikely to be statistically significant. Target vessel MI, very similar, and then a slightly higher rate of clinically driven target vessel revasc in the solution arm. But I would also point out that when we're doing these cases, some of these people end up with dissections and come back with non-cardiac chest pain, and people end up seeing what was done before because they don't like the look of it and put a stent in. So I think there's more work we need to do to understand whether these were all true, clinically driven, or whether this was an uncomfortableness with what was left. What about safety endpoints? Clearly that's really important when we're talking about non-inferiority. Pleased to say there were no real significant differences between the two groups. And this was their summary slide. At 1 year, a strategy of PCI with solution and provisional drug-eluting stent was non-inferior to the systematic use of drug-eluting stent for the primary endpoint of target vessel failure. So I'll bring you back to that case that we did, that right coronary artery, and he came back with to have assessment of a bystander vessel, and this is what his right coronary artery looked like 3 months later. As you can see, nicely healed. I think a great result for a young man. I'll just remind you what it looked like at the beginning and how the dissections had looked at the time. I thought I'd just share some final thoughts, which I think are important. As I already mentioned, this was a very broadly inclusive study, and it was unusual that people couldn't go in when they were coming through my lab. But of course, there are areas we need to do further analysis on. We need to understand STEMI, CTO, left main in particular. The use of scoring and cutting balloons was overall low in the stent arm, but of course this reflects real-world practice, and similarly with intracoronary imaging, again reflecting real-world practice. But the rate of intracoronary imaging in the drug-eluting balloon arm was similar to the stent arm, but at the moment we don't know what we're aiming for. We've got a lot to learn about what we're trying to achieve when implanting a drug-eluting balloon. We talked about this at the beginning. Not all balloons are the same. We can see the elution profile for the solution is similar to a stent, but the Magic Touch balloon doesn't perform as well. And we know already that the paclitaxel balloon in ret cage free didn't perform as well as stents. I think the other thing that's important to note about this is I learnt my drug-eluting balloon PCI during the study. And so this was a study of people who were right at the beginning of their drug-coated balloon learning curve with those who were experts in drug-eluting PCI, drug-eluting stent PCI. And what this means is that as we learn, it's possible that we've now got better at doing it. So if we repeated it, we might not make those errors that we did originally. And this was shown when they presented the data at PCR a year ago, where they showed that as we learnt, our crossover rate dropped. We don't have the QCA data as yet, and I think that's going to be really important because, as I said, there were these criteria which were considered acceptable angiographic results. Now, there will be some in there that were considered not acceptable, and I suspect that if we just look at the angiographically acceptable ones rather than the entire lot, things might even get better. What about the future? Well, here are some studies using drug-coated balloons, and you can see that the drug-coated balloon arm does seem to flatten off with time. Now, I accept that these are small and the numbers involved are relatively small, but I do wonder whether now we've not left a metal scaffold behind, we will see a flattening off of this curve. So thank you for listening to me. I'm really excited about the discussion that we're going to have here, and I'm grateful for Cordis, who are going to arrange some times to talk later and discuss these cases in more detail. And I'm around here if people want to catch me at some point, and I'm very happy to be emailed to discuss further. So thank you very much.
Thank you very much. I'll take one comment from panelists before we move to the next speaker. Wonderful.
First, thank you for your nice illustration for this is very important trial that we've been waiting for some time, and it's probably now the largest randomized trial in DCBs. However, I'd like to your comment on low rate of IVUS use. You know, IVUS is class 1 indication to be used in DS. So, and maybe if they have been using more IVUS, the stent arm will be higher. Second, numerically, the number of events was higher in DCB. So I think my take home from this study that DCB is safe, and, but it's probably early to say it is as good as or superior to current practice. What's your thought?
Two interesting questions, thanks. I think the comment about intracoronary imaging is really important, and I agree that we should all be using it more, but that does reflect real-world practice. I suspect that we could have done better with our stenting if the more intracoronary imaging was used, but I suspect there's also a lot of room to improve our drug-coated balloon treatment by using and understanding what we're aiming for in intracoronary imaging. And to your second question, which was around the numerical difference, I think that's an important observation. We know from the data that this is a safe treatment, and the statistics behind this were non-inferiority. And of course, there will always be a difference in the numbers, but the non-inferiority margin was met. And as I pointed out, those who had DEB only, not had stents, actually did better numerically. Of course, it won't be statistically significant, 5.3 versus 5.0, but they did numerically better.
Okay, thank you very much. We'll move now. You heard the evidence, but evidence is useless unless it's done properly. So we need to see how lesion modified, prepared before we use the evidence. Dr. Hussien Heshmat.
Thank you, Dr. Abdullah, and I'm glad to be speaking after Dr. Hinton, because what he talked about was a very sophisticated, advanced technology, a study that was published just last month. Well, I'll be taking it from the other extreme side. I'll be talking about very basic pathological concepts that we forgot while we were chasing the strut thickness and the stent fracture and the geographic miss and the stent under expansion. So I'll start with my current situation. My personal approach is from every 5 lesions that I treat, 4 will end up being treated by a DCB and 1 will end up being treated by a stent. Yes, I still use stent for patients with aortoosteal lesions, whenever there's a heavy thrombus burden, whenever lesion modification fails, or whenever there's a stent fracture, or when I'm unable to modify the atheroma properly. But you see the common word, the common terminology between DCB and drug-eluting stents is lesion modification. And I think this is the more correct terminology rather than vessel preparation, because semantically, preparation means that you are preparing for something to come. But lesion modification means that you are modifying the pathology of the disease, and that's the word, that's the term I prefer. So in the coming few slides, I'll take you back to the basics. What is the lesion and what is the modification? A gentle reminder that the lesion that we're talking about is the atherosclerotic plaque when it has grown large enough that we call it an atheroma. An atheroma in Greek means a tumor or a swelling. And these plaques keep growing since early adulthood until they grow enough in the 40s or the 50s, and they have one of 2 pathways. The benign pathway where they keep growing like a benign tumor and occluding the lumen, or the complicated pathway where they rupture. And if you go to the basic surgical techniques, when you have a benign tumor that's obstructing a lumen, then you have to excise it. And when you have an abscess, you have to drain it. And this is exactly what we do with coronary angioplasty. When we put the balloon inside the vessel and we inflate it, what we basically do is we rupture the plaque, and we do it in a controlled manner so that its contents are released in the blood in a condition where the patient is anticoagulated and on good antiplatelets. So we denude the intima, we hit the plaque and eviscerate its components, and in addition, we induce some stretch of the vessel wall. And imagine that you have this tumor living inside the vessel wall and you smash it or you slash it. Then we have a dissection. So dissection is the essence of coronary angioplasty, and I will show you in the coming slides how we should be comfortable doing the dissection. But what happens after lesion modification? Whether you do a balloon or a stent, you inflict strong trauma to the vessel wall. So you injure the vessel wall. And how do vessels react? They react by proliferation of endothelial cells and vascular smooth muscle cells, giving us the neointima. And this neointima is a friend and a foe. It's a friend because it's very slippery. You know, when you're doing in-stent restenosis, the balloon keeps slipping. So this neointima is slippery and it is very resistant to thrombus formation. That's why in all the trials of DCB versus drug-eluting stents, myocardial infarction was considerably low with drug-coated balloons. But excessive neointimal hyperplasia would result in restenosis of the vessel again, and that's what we need to fight with the balloons or with the stents. So we discussed the lesion. What is the modification? We do the modification by several tools, and I would like to give it the term proportionate use of force. Whenever there's a thrombus, then we do the simplest maneuver, thrombus aspiration. For straightforward lesions, an NC balloon or semi-compliant balloon would be enough. When there's a fibrotic lesion at the bifurcation or a large plaque burden, then we like to go for specialty balloons, scoring and cutting balloons. As it gets more calcified, we incline towards the cutting balloons and, of course, the IVL, the rotational atherectomy and the orbital atherectomy. And I would invite you tomorrow to attend at 9 a.m. where Dr. Shehab will be presenting our consensus document on drug-coated balloons in the Gulf region, and there will be more elaboration on lesion modification tools. Once you've done the lesion modification to the best of your supplies and the best of your abilities, then you sit back and look to decide, are we going for a balloon, a DCB, or you're going for a drug-eluting stent? And the criteria are more or less simple. You look at the flow, and that's easy, TIMI3 flow. If you don't have TIMI3 flow, then the preference is for stent. And then you look at the residual narrowing and at the extent of the dissection. And these are the tricky situations where we need to be sure about. So residual stenosis of 30%, 40%, you know there's a big inter-observer difference. I would see a lesion and call it, this is 40%. A colleague may see it and say, no, 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 this is 60%. So in order to make it more objective, you can count on coronary physiology, or maybe you can count on intracoronary imaging. But why do we accept 30% or 40% residual narrowing? Because the advantage of DCB is that they allow for late vessel remodeling. We've seen that after 6 months of using the balloons. And if you are in doubt, recently I like to use the pressure wire and keep it all through the procedure because it helps me to understand what's going on. And the standard that we have comes from Korea. I'm not endorsing this. I usually like to achieve better numbers, but the numbers for DCB are slightly lower than the stents. You can accept the result with DCB if the FFR is 0.75, not 0.8, or an IFR of 0.86, not a 0.89 as we see with stents. So if you are in doubt, have the FFR wire and take the measurement. So that's for the residual stenosis. Now about the dissection. Everyone is scared about the dissection. And as I told you, I'll bring you very old studies, not the recent ones like Dr. Hinton's. So this is a study that is 33 years old. And it helps us to understand the mechanisms of success of angioplasty and failure of angioplasty. You see, these are in the early days of angioplasty and IVUS. And what they did is that they looked at dissection after plain old balloon angioplasty. In 47 lesions, dissection was seen in the majority. You could see it on IVUS and don't see it on angiography, and it could be the other way around. You see it on angiography and don't see it on IVUS. And they had their nice grading of dissection from A to C or D. So A is a slight dissection that's extending just into the plaque. B is a dissection that's extending all the way to the plaque, but not into the media. C is a tear that extends into the media, that's a slashing dissection where D is a dissection plan that is more extensive and encompasses an arc of more than 180 or 360. Whereas E is just stretch of the vessel. There's no dissection at all. So D is the worst type of dissection, and A is the minimal dissection, and E is no dissection. And then they got these patients and had an angiographic follow-up 6 months later. And they correlated the extent of the dissection with the chances of restenosis. And for your surprise, those patients without dissection, they had the highest rates of restenosis. Whereas those patients with the most extensive dissections, they had the lowest rates of restenosis with plain old balloon angioplasty. This study has been more or less replicated in a recent Japanese study where they tried to index the dissection in an objective manner by a motorized pullback of IVUS. And they found that whenever the dissection index increases, then the late lumen enlargement becomes more obvious and the atheroma tends to shrink more and more. So practically, how would we handle that? And I like this acronym by Simon Eccleshall and his colleagues about the ARM: avoid, recognize, and manage. So how to avoid? You need to predict which lesions will dissect badly. Elderly patients, long lesions, tortuous lesions, large-sized balloons, higher inflation pressures. Of course, these can give you a worrisome dissection. And then you recognize, you basically look at the grade of flow and you look at the hanging of contrast, because if the contrast keeps hanging even after you remove your foot off the fluoroscopy, it means that the false lumen or the neolumen is filling with blood, but it's not draining. So if you leave it like that, maybe in a few hours it will expand, compress the lumen, and give you an abrupt vessel occlusion. Of course, if the patient has continued pain or ECG changes, then you should do something about the dissection. And I'm mentioning this because I would recommend that we forget completely about this National Heart, Lung and Blood Institute grading of dissection, because it's very impractical standing in the cath lab to remember a dissection that's composed of 6 degrees. No human brain will be able to analyze that. And I'm glad that we wrote this editorial with Dr. Shehab in the American Journal of Cardiology, and we like the term 30-3-30. Contrast hanging for 30 seconds, TIMI-3 flow less than 3, or a residual stenosis more than 30%, then you cannot leave that dissection and you need to handle it some way. So how would you handle that? The easy way, of course, is to stent, but you know we don't like stents. So there are ways around that. And one of the nice techniques by Gabriele Gasparini, it's called the cuttering technique, where you get the cutting balloon, sometimes a scoring balloon can work, and you keep dottering it into the area where there's been a dissection. So what you do is you cut the intima completely. So you open the false lumen and the true lumen as one communication, so there's no chance that the false lumen will ever compress the true lumen. If you're not comfortable with that and you would like to put the stent, then it's your call. And I'll finish with just one quick real-life case. A young gentleman, like most of our patients, 48-year-old gentleman with crescendo angina, a normal ejection fraction, and you see a nice focal lesion in the circumflex. We dilated that with a 3.5 NC balloon, and you see here that after waiting for a few minutes, we didn't have vessel recoil, we have TIMI-3 flow, but we have some dissection. Of course, we didn't worry about that, so we went ahead with a large and long solution, 3.5 by 40, and this is the final result in 2 projections. You have very nice flow, no significant residual narrowing, but you still see the dissection flap. We were not worried about that at all until the patient came 5 months later. He had some acute bronchitis and chest pain, so I said, let's go ahead and do a coronary CT scan. I didn't want to take him for angiography again. And this is what we found on CT angiography. We reassured the patient. He came back 8 months later and he landed in my colleague's call, so he decided to do an angiography. And this is what we find on angiography. The dissection that was there 8 months ago has completely disappeared. So if you would like to pursue a metal-free angioplasty, Remember that the aim of angioplasty is to disrupt the atheroma. The aim of DCB is to control the neointimal hyperplasia. Spend some time in assessing the residual narrowing. Use imaging, use coronary physiology. Remember the acronym anticipate, recognize, and manage. Remember the 30-3-30 rule for dissection. And thank you so much.
Thank you, Hani.